Alright, we're on the last section of our fire and disaster manual. This is the evacuation procedures section. This discusses the issues around evacuation, which can be a very serious situation, especially for a facility like All Saints when most of our facility are subacute patients. Evacuation would be a big deal. Monostation is less so. It'd be much easier to take those patients, put them in wheelchairs or in other ways, even rolling their bed outside the facility for a quick evacuation. But when we have these patients on oxygen and need a lot of suctioning, it's a much more serious issue, but we do need to have a plan in place. So this goes through the issues, and a broad idea to remember when you're talking about evacuation is we evacuate the patients first who have the best chance of survival. Let's say we had a bad earthquake. Think of the most dependent patient imaginable, who's on oxygen, who's an obese patient, who's comatose. That would not be the first patient that we would want to take out. We'd want to take an ambulatory patient out first. The one that's maybe on room air with a trach. The one that doesn't need much suctioning. Those are the patients we rescue first in an evacuation. Unfortunately, the heavier care patients would be the last ones we want to prioritize. This discusses also when you evacuate, we want to take the necessary medical supplies, the necessary medications, the chart, and any essential equipment. I have here the evacuation maps for each of the 3 buildings. It shows on each of these an evacuation area, an area that is on the same level just outside, usually the main entrance, to where you want to evacuate for rapid evacuation. The next section is for prompt discharge or transfer of patients. So if during a large-scale disaster we need to really consolidate our resources, we would want to consider doing a prompt discharge of patients to, for instance, those who can be discharged without jeopardy into the community. This would be most likely a mono patient who has a family member who lives nearby, who is a fairly easy patient that they could take care of. We want to give them a call and say, can you come take your loved one home until the disaster is over? And if they say yes, absolutely, that would be a good idea and take some of the pressure off the facility. We can focus on the patients that we have left. Relocation to other facilities. If we need to, if we're not sending them to the hospital, but we need to transfer patients out because we're overwhelmed, then we can of course transfer first between our buildings on the campus. Secondly, we have sister facilities nearby, such as Valley Point and St. John's, and we can coordinate with them if they have beds available that they could accept our residents. Next is evacuation transportation. If it's an internal disaster, just a small, just All Saints for example, we would definitely call 911 for evacuation transportation because they need to send a lot of ambulances. For large-scale disaster, 911 will probably be overwhelmed, so we have backup transportation that we have ambulance companies listed that we could call. We have Gurney Transport listed. We have a local private bus system called Go Green Transportation. They could do take some wheelchair patients. East Bay Paratransit is listed. We want as many options as possible to make arrangements. Also, the last option, if there's nothing else available except a staff member who's able to move a patient, and that's necessary, the incident commander may authorize a staff member to use their own vehicle to transport a patient if that is our last option. Following an evacuation, we have to, of course, keep track of where patients are going and have a disaster medical record that we're going to send with them. Disaster medical record, the ideal medical record is listed here. Take the face sheet and the current physician orders, current diagnoses, and for instance staple that packet to the patient's clothing. Sometimes you don't have time to do that. We also have this option. We have disaster transfer tags in our disaster kits. We have two types. The first type is a carbon copy triplicate form where you fill out the essential information and you take a copy and keep it here. You send the rest, tie it to the patient's wrist or ankle or clothing, and send that with them when you transfer them out. The other option is the Alameda County transfer tag. It's not carbon copy. You just fill out the essential things and you keep the bottom receipt here. You tear off the bottom receipt, which keeps the serial number for tracking that patient, and we keep that receipt. The rest is again tied to the patient. If also in an emergency, if there are no other options and you have to send our chart with the patient, that is okay if, again, you have no other options and that is essential for the safety of the resident. You may be authorized to do that. And there's some discussion of how to keep track of disaster medical records. The last page is emergency phone tree. It's how we spread out calls to all the staff to make sure that everyone gets called in and is informed of the issue. That concludes our fire and disaster manual training. Please be familiar with this. You don't need to memorize it, but you need to know how to reference it in case of a disaster. Thank you.